So you see blood in the bathroom. Let's be real, our minds instantly jump to the absolute worst-case scenario, right? It's terrifying. But today, we are going to demystify this incredibly common, highly anxiety-inducing symptom. We're going to break it all down by comparing its most frequent benign cause, hemorrhoids, with its most severe malignant one, colorectal cancer.
Here is our roadmap for today's explainer. We'll start with introduction and epidemiology, move into etiology and pathophysiology, then clinical signs and differentials. After that, we'll cover investigation and diagnosis, management and complications, and finally wrap things up with prognosis and prevention.
Okay, let's kick things off with Section 1, Introduction and Epidemiology.
It's actually kind of fascinating to realize that we all have these vascular structures right there in the anal canal to help maintain continence. They are completely normal anatomical features. They only become what we call hemorrhoids when they enlarge. The problem really only starts when these fragile little cushions stretch out way too much, and, well, that is exactly when they bleed.
Now, looking at who actually gets these conditions, there is a pretty stark demographic divide. While hemorrhoids are incredibly common and typically start showing up around age 30, the incidence of colorectal cancer sharply rises after you hit 50. And it's worth noting that while colorectal cancer rates used to be lower in certain regions, like many African countries, global dietary shifts and better diagnostic tools are driving a universal increase. It's literally a leading cause of cancer mortality worldwide right now.
Moving right along to Section 2, Etiology and Pathophysiology. So what actually causes all of this? Well, benign bleeding is really all about mechanical pressure. We're talking chronic constipation, straining, prolonged sitting, or pregnancy, basically anything that overloads the pelvic veins. Malignant bleeding, on the other hand, is a much deeper systemic issue. It's triggered by things like being over 50, genetics and family history, existing inflammatory bowel disease, and eating a diet high in red and processed meats. Now, this is absolutely crucial to understand. Cancer doesn't just happen overnight. It follows a very predictable sequence. It transitions slowly from normal mucosal cells into benign adenomatous polyps and eventually mutates into an invasive cancer. This slow buildup, known as the adenoma-carcinoma sequence, is exactly why preventative screening is so remarkably effective. You literally have a window to catch it early.
Mechanically speaking, hemorrhoid bleeding is essentially a burst, dilated vein under pressure. Think of it kind of like a popped balloon during defecation. A tumor, however, acts completely differently. As it grows, it creates its own chaotic, highly fragile vascular network. That tissue ulcerates and bleeds just from stool passing by.
All right, let's dive into Section 3, Clinical Signs and Differentials.
You might be wondering, why do doctors always grill you for a precise description of the blood? Well, the visual characteristics offer massive, immediate clues to the source. The human digestive tract is pretty long, and blood changes color as it travels and mixes with digestive enzymes and stool.
Here's how that plays out. Because hemorrhoids are right at the exit, the blood is fresh. It's bright red, usually painless, and often just seen on the toilet paper or associated with anal itching and prolapse. Cancer, though, is further up the tract. That results in darker blood that's mixed deeply into the stool. Plus, it's often accompanied by major systemic alarms. We're talking unexplained weight loss, a sudden shift in bowel habits, and profound fatigue from anemia.
Keep in mind, though, these aren't our only two suspects in the lineup. Conditions like anal fissures, inflammatory bowel disease, diverticular disease, or even completely non-cancerous rectal polyps can mimic these exact same symptoms. And that is exactly why professional clinical evaluation is absolutely paramount to rule them out.
Which brings us to Section 4, Investigation and Diagnosis.
Diagnosis follows a very strict, step-by-step clinical escalation. A simple visual inspection, a digital rectal exam, or a proctoscopy can usually spot hemorrhoids immediately. But to absolutely rule out cancer, especially, and I mean especially for patients over 50, a colonoscopy is the gold standard. It allows doctors to visualize the entire colon and take biopsies right then and there.
Now, if malignancy is suspected, doctors are going to cast a much wider net. A full blood count will quickly reveal if the patient has become anemic from occult or hidden bleeding. And if a biopsy confirms a tumor, CT and MRI scans become the roadmap. They tell the surgical team exactly how far the tumor has progressed and if it's spread to any other organs.
Let's jump into Section 5, Management and Complications. Reassuringly, hemorrhoids rarely actually need surgery.
Simply upping your water and fiber intake or maybe using stool softeners usually solves the whole problem. If they do persist, quick, minimally invasive clinic procedures like rubber band ligation or sclerotherapy can just cut off the blood supply. Really, only the most severe prolapsed cases require a full surgical hemorrhoidectomy.
Conversely, managing cancer requires a heavy-hitting, multidisciplinary approach. The primary goal is surgical resection, literally removing the tumor and the surrounding affected tissue entirely. Depending on the stage, this is flanked by chemotherapy. And specifically for rectal cancers, radiotherapy is frequently used to shrink the tumor down before surgery even happens.
The stakes of leaving these two conditions untreated are wildly different. A thrombosed hemorrhoid, where a blood clot forms inside the vein, is excruciatingly painful for sure, but it is localized. Advanced colorectal cancer, however, can literally block the intestines, perforate the bowel wall, or aggressively metastasize to major organs like the liver.
And finally, we arrive at Section 6, Prognosis and Prevention.
The really great news here is that if your bleeding is just hemorrhoids, the long-term outlook is incredibly positive. It's super easily managed, it's a total annoyance, certainly, but it's a completely solvable one that doesn't impact your overall life expectancy whatsoever.
But if the cause happens to be malignant, your absolute most important takeaway from this explainer should be this. Early detection drastically changes your survival odds. Because colorectal cancer follows that slow adenoma-carcinoma sequence we talked about earlier, intercepting it while it's still just a harmless polyp provides truly excellent survival rates. When that diagnosis is delayed, unfortunately, the prognosis plummets.
So, how do we stop this? Your daily defense is actually surprisingly simple. A high-fiber diet packed with fruits, veggies, and whole grains prevents the mechanical strain of hemorrhoids while simultaneously nourishing a healthy colon environment to fight off cancer. Add in some regular physical activity, cut back on the red meat, and ensure you schedule that colonoscopy past age 50. Do those things and your defenses are set.